It is good to see you, my friend. This is Glenn Loury, The Glenn Show at bloggingheads.tv. And I am with Josiah Rich, Dr. Josiah Rich, who is a professor of epidemiology in the School of Public Health and professor of infectious disease medicine in the medical school here at Brown University. We're both faculty at Brown University. I'm with the economics department in the Watson Institute. Watson Institute sponsors The Glenn Show. So I'm very happy to be welcoming my friend, because we've known each other for a long time. I could go all the way back to when I first met you and Scott Allen. You guys had founded the Center for Prisoner Health, if I'm not mistaken, here at Brown.
Yep.
And that's going all the way back. That's kind of like when I first came to Brown 15 years ago. Jody is an infectious disease specialist, and the Center for Prisoner Health at Brown has been very involved over an extended period of time in advocating for and seeing after the health needs of incarcerated persons in the state of Rhode Island and beyond. Jody and I served on a National Academy of Sciences sponsored committee looking at the causes and consequences of high rates of incarceration, and have been bumping into each other around the Brown campus for over a decade. So again, welcome. COVID-19, Jody, you're on the front lines, both as a scholar. You guys should know that he's published in peer-reviewed journals. I mean, it goes on for page after page after page on his CV. But also as someone who, trying to take care of people who have HIV infection in prisons inside of the state of Rhode Island and whatnot. So I'm sorry, I don't need to be talking. You need to be talking. How are you processing the pandemic catastrophe that seems to have befallen us on so many levels? I know you're seeing patients. I know you must be thinking about treatment and about the controlling of the spread of the disease and whatnot. I just love to hear from you about that.
Well, Glenn, I've seen a number of my worlds sort of colliding here. My training in epidemiology and public health, in medicine and infectious disease, in disadvantaged populations, and it's all seems to be sort of exploding for me. We've watched this epidemic unfold with horror and fascination, and sort of scrambled the best we can to think about how to take care of this avalanche, this tsunami of patients that are coming our way. In Rhode Island, so far, there's just been a sort of a steady increase rather than the overwhelming wave of patients in New York to our south and even in Massachusetts to our north. So we're keeping our heads afloat, but this is a serious illness, and we've seen more than enough deaths already, and others have seen many more. We've seen a lot of successes, people getting better, even people that are older that have a lot of comorbid medical issues that predict that they would not do well. So and we're scrambling to try and help with whatever we can about getting the best treatments to people. There's one clinical trial that our group has been sort of pushing because we think that's probably the most effective treatment from the available options at the present time. So we're trying to get that out to people. It's too early to say whether it's certainly not the magic bullet cure. People aren't rising from the dead, but we think it does help a bit, and so we're trying to get that out.
What is that?
Well, there's an antiviral compound called remdesivir, and seems to have good activity against the coronavirus. It was developed to really address the Ebola virus, and was tried 500 people before this trial, before this epidemic came along. So
you have a trial ongoing, I'm sorry, here at the medical school?
Yeah, we've enrolled, I think, 60 patients. I think we're the third highest enroller in the country. And we really, the very first patient in Rhode Island who got infected was a 48-year-old school teacher who took a trip of students to Italy. And he was standing at the front of the tour bus, and he was speaking on the microphone. And the tour guide he was passing the microphone back and forth, and the tour guide was ill and was coughing away, and they were just passing this microphone back and forth. And then he got very, very sick. Ended up in intensive care unit, ended up intubated. And my colleague, Tim Flanagan, who was on service that day, had known about this medication, had known that the pharmaceutical company that made it, and called about 8 different people on a Saturday morning to try and get, when it was clear that he was getting a lot worse, and really pushed to get him onto that medication, which took him, he got the first flight out the following morning on a Sunday morning, and got dosed that afternoon, and
saved his life.
Better after that, and eventually he was able to get out. There was actually a Wall Street Journal article about him, but that was a wake-up call to all of us. I mean, we'd heard, oh, this is older people. Well, there's going to be the geriatric crowd. They're going to get sick and die from this, and to see someone in their 40s, father young kids, and
so what do you think about the debate over hydroxychloroquine?
Well, I don't know that there's a debate. There's some in vitro suggestion that it may have some activity against this virus, I think we need to study it to try and figure that out. There are trials ongoing. I think it's too early to say if there's going to be where we'll end up in either of these medicines. But, when you have nothing left to offer, we are offering it in some patients. We're not offering it in a lot of patients who have contraindications to that medication. That can be a dangerous medication, as we all heard that somebody took their fish tank chloroquine and killed himself, nearly killed his wife too. So, we're scrambling to try and identify effective antiviral treatments. And the other push that we're doing right now is to try and use convalescent serum. People that have already been infected that have developed antibodies. And this has been used in other disease settings for a long time.
Are there trials underway on that?
So there's trials underway. We are hoping to be a site for that probably this week to see if that can help. Anyhow, it's the whole hospital, inside the hospital, things have been turned upside down. They are, the whole census has gone way down because rightfully people don't want to go into a hospital because it's a hot zone. So a lot of elective admissions. It's remarkable how much fewer. This elective surgery shut down weeks ago, so that helped. And
are you sure that that's a prudent way to handle the situation?
Well, you mean in terms of cutting back on elective?
I assume the debate is, on the one hand, we need capacity, and that it's a kind of prioritization. And perhaps it's also a kind of social distancing where we don't want to bring people in unless we absolutely need to. On the other hand, though, I can imagine there's a cost side to postponing procedures, even elective procedures, especially if they're diagnostic in nature, and people delay learning what they might otherwise have learned from coming to the hospital to have a mammogram or whatever. I don't necessarily know what I'm talking about, so I'm just putting that on the table for you to critique it and correct it.
Yeah, I have a good friend who's elderly and was scheduled to have her knee replaced, and is postponing that, and is kind of
There's
locked
some,
alone in her place and can't really go out and get the exercise she needs for her mental health. But that's she's much better off than if she came in the hospital. And
can I ask you about the search for effective treatment? Uh, do you guys know what's going on at the microbiological level in terms of being able to impede the virus's ability to degrade and adversely affect the human body? Or are you like shooting at the dark, trying this, trying that? Maybe it works, maybe it doesn't. We want to make sure we go through trials, but we don't necessarily understand the mechanism.
No, I think we understand a lot of the mechanism, and I'm not expert in that realm, but we understand coronaviruses and how they replicate and how they attach onto other different cells. So there is a fair amount we know generically about coronaviruses, and we're learning more about this particular one by the moment, I'm sure. So that's been an adventure to try and understand this disease both clinically and try and scramble to get the best therapeutics and try and understand not only as that's going on, trying to figure out how are we going to ramp up and deal with this, what we've seen. We saw this coming. We saw it happen in China. We saw it happen in Italy. We saw it happen in the rest of Europe, and we saw it happen in New York, and now it's happening, right now here for us. So we're learning little bits and pieces and on how to better deal with it. And I'm just thinking about, as our hospital starting to fill up with these very sick patients, how much farther along we are than the poor people in China. When the first cases came through, I had no idea what was coming through, but knew there was something, and then figured it out. And then, it's really it's a testament to our abilities that we've actually figured out what this virus was quickly, and how it presented clinically, and how to develop the test for it. That's all been at lightning speed. And of course, there are a lot of mistakes made, and we are far worse off than we could have been. But we also could have even been far worse off had we not had that capacity to build that. But again, when this first came out in China, one of the early things that we noticed was there was a large number of prisoners that got infected all at once. And that was, as we're realizing how this transmits, and how the people are, many of them are probably contagious before they get symptoms. We were just learning that. Now we know, of course, there's a lot of people that are likely contagious that don't have any symptoms. And that there is, rapid person-to-person transmission, and that it can spread through a congregate setting very rapidly. So we've known this about different infectious diseases that are, transmitted human to human, either airborne or through objects that you touch or cough on or sneeze on, so-called fomites. And we've known that, there have been outbreaks of diseases in military barracks and college dormitories and other congregate settings. And here we've just seen it play out. Boom, there's a cruise ship. Wow, look at that take off. And oh, look at, there's a nursing home. Boom, that look. And then these correctional facilities. So that was, I guess, February that those reports came out of China about the correctional spread. And so it became apparent pretty quickly that this is going to happen here, because of course we're the lead incarcerator in the world, and we have 2.3 million people behind bars that are susceptible. And when we look at those people, about half of them have at least one chronic medical condition, which would put them at increased risk for becoming one of those more severely impacted people that get sick. So again, 80% of people, they're going to get this, they're going to do fine. 20% are going to get sick enough to need to be in the hospital. 5% of the total are probably going to need intensive care and maybe intubation and put on a ventilator. So looking at that proportion, as this spreads through correctional facilities that we know have people with chronic disease, we know that our policies of the last decades of harsher and harsher punishments have increased the aging of our incarcerated population, that we have a large group of people that are going to not do well with this virus. Now, of course, correctional settings don't have hospitals on site for the most part. They don't have the ability to give any kind of intensive care. Some of them have some capacity to give oxygen, but most don't have that kind of. So, of course, these are people that are going to need to be transferred out into local healthcare facilities. And then we realized that the magnitude of this epidemic, that people, first of all, you're likely to have very rapid spread through correctional facilities, and people, large number of people infected all at once. And that'll put a huge burden onto the local healthcare settings. I can only imagine what's going on right now in Rikers Island in New York City, when New York has been, at or above capacity to deal with people. We saw in Italy, the disease took off and the mortality rate was going up, and then there was a bend in the curve right when they hit capacity. So when you run out of ventilators, when you run out of space in the emergency room, space in the hospital, that's when people, and these people I've been taking care of for the past month, that if you give them enough support, most of them will make it through it if you can give them enough support. But the point is, when your hospital system is overwhelmed, people can't even get that kind of support. And I would say many of the people that get hospitalized would not survive. And I'm not talking about all the ones that go to the intensive care unit. The ones that stay on the floor and just need some oxygen support, if they didn't get that, many of them would die. So
now, I've been reading reports in the last day or two about New York City hospital capacity. Javits Center, for example, being very much under full capacity utilization, that suggests that it hasn't developed to be as much of a constraint as people had initially thought it would be. Is that right? Or have we just not gotten to that point yet?
Well, there's a lot of talk about trying to flatten the curve, and I think that's what we're trying to do. But when you look at the images of those emergency rooms just jammed up with stretchers, and it's hard to give the kind of close attention to people that they need. And we can see people get sick very quickly with this. So you can put them off in the corner and give them some oxygen, but if you're not paying close attention, when you turn around, they're going to be like desperate, and you need to rush in and put them on a ventilator and get them to intensive care unit. So as people get very sick very quickly, if they're in a care environment where there's not enough people paying close enough attention, that people can get, if that happens, then people start, the mortality starts to go up.
Okay, you spoke about the potential for disaster inside of the confined area of a prison. Are we in fact seeing that? You said you can't imagine what happens at Rikers Island. What do we know about the health condition of people confined at Rikers Island and other such places, Cook County Jail in Chicago, et cetera?
So there are news reports coming out, and the chief health officer at Rikers Island issued a desperate appeal to release people. So you have people in these congregate settings. What can you do to try and reduce them all getting infected at once and overwhelming the health system and overwhelming the correctional system? And the first thing you can do is try and get as many people out as possible. And when we think about why we incarcerate people. And I guess I'm a bit biased by the fact that for the last 25 years, I've spent time every week behind bars taking care of people. So I've met thousands and thousands of people, and as their physician, and I have, heard their personal stories and got to know them as individuals. And I know that most people don't need to be locked up and don't need to be locked up for that long. And if we just simply take a look at the rest of the world, somehow every other functioning society is able to function with incarcerating just a fraction of the people that we incarcerate. So I don't think there's anything very different about the people in America versus people all over the world. And I think it's really our approach that's causing trouble. But it's often justified in well, people need to be locked up for public safety. You mentioned Scott Allen. Scott Allen is now in Riverside, California. He's involved in their local correctional system there as providing some sort of oversight. And he brought this to the sheriff's attention early. There's going to be an outbreak here, and this should be prevented. And we should let as many people out as possible before the break happens. And he went on record, the sheriff, in public, and said there's not a single person out of these 3,000 people that should not be here. This is all a public safety risk. Every single individual, and the public safety risk is greater by letting than to let them out than by any kind of epidemic that might happen behind bars here.
Well, if I may, it's obvious to me why that sheriff and every other sheriff has to say what you just got through saying he said, which is that if the random event of a pandemic, which exposes the vulnerability of these people who are confined, were to be met by simply letting them out, then the legitimacy of having locked them up in the first place or returning to locking them up when the pandemic is over will have been completely eviscerated. So he can't let them out. I mean, am I wrong in that?
Well, that's his party line, but that was 3 weeks ago that he said that. And in those interim 3 weeks, they've had an outbreak. They've had an epidemic there.
This is Riverside that you're talking about.
Riverside County, California. And 2 correctional officers have died from coronavirus that they've got infected on the job. So I think, we need to really re-examine what we're talking about when we say public safety. Those correctional officers died specifically because of the job they had and because of the outbreak that occurred there, because all of these people are in a congregate setting. So that, I can hardly imagine that any of those 3,000 people let out would go and kill a couple of correctional officers within a few weeks.
We won't gather in a football stadium or a basketball stadium. We won't even have a faculty meeting in which 30 people come together and get into the same room. We won't allow people to sit in a restaurant dining room and eat, all breathing the same air. We got trepidations about getting on a bus if people don't have a mask, but we can take hundreds upon hundreds of people, pile them on top of each other in very confined circumstances, and know, just like the captain of that aircraft carrier who got himself into trouble by desperately pleading that the carrier be evacuated of the servicemen there because the sailors were exposed to it and he was worried about a pandemic. We got an aircraft carrier floating around in Midtown, every big city in the country, full of some of the least advantaged people in our society. Yes, they may have offended against some rule or stricture in some way or another. You think they've not earned the punishment of a death sentence or a severe illness sentence by being confined in prison? We should let them out. Is that your argument?
Well, there is a balance. There's a risk, there's a trade-off. So that balance has all of a sudden shifted. That now, we're where public safety is threatened by the mere existence of all of these people in these confined settings. So it's those people that are at risk, it's the correctional officers that are at risk, but if they get sick and get transferred out to a local hospital, and you know, we are looking at correctional facilities all over the world, all over the country, and detainment centers as well. Many of those are in very remote areas, so there isn't a hospital nearby, or it could be quite a distance. So there's a regional medical center, and that has a very limited capacity. So if that could easily be overrun by the people coming from corrections, and at that point, yeah, there's going to be people that have COVID-19 that are not going to be getting the treatment they need because the inn is full. But there's also going to be people having heart attacks and broken bones and car accidents and other life-threatening illnesses that are going to be able to get treatment in those settings because the settings are overrun. So it's not just the health of the people behind bars. It's not just the health of the people that work there and their families. It's the health of the general public as well. So this is highlighting an additional expense, a very expensive cost of maintaining this institutions of large congregate settings. So on an individual patient, I was trying to do some work and trying to get this word out at many places, and had a number of interviews with the press, and wrote some op-eds, notably one in Washington Post and another in New England Journal of Medicine, really trying to get the word out. And one person wrote back and said, well, what do you want me to release all the murderers and rapists and child molesters? I said, we have a very narrow window of opportunity here to get people out before spread happens. So I would start, if you're thinking about classifying individuals who are incarcerated by their charge or their conviction, then start with the easiest ones first. Because the first step is get people out, and the people you want to get out, the first ones you want to get out are the ones at higher risk for getting disease, the ones with the chronic conditions. But getting anybody out is also a benefit, because that's just less people that get infected, but it also takes pressure off the inside of the facility. So if you have a hospital and you have one open wing, then you can move people who are infected all over to that wing and cohort them. And that gives you some breathing room rather than keep them in the population with everyone else. Not that that's going to be completely effective, but it'll give you some ability to slow the spread of this virus in this settings. Ultimately, I believe those kind of measures are mostly going to be futile in the long run, that most people in these settings are going to be hard to keep them from getting infected. But it may slow it down enough so that you don't have a big burst of people going to the local healthcare facilities.
This is what you see coming then.
Oh, it's here. So Cook County has the highest concentration of coronavirus patients in the country.
I didn't know that.
That was just in the news.
Are you talking about the correctional facility?
The correctional facility, highest density of infections. That was just the headline I saw. I haven't been. I've just been on call this past week, so I've spent every day in the hospital, and that's been pretty busy. And after we get off this call, I'm going to be have a whole bunch of patients who've been discharged. I'm going to call and check on them and see how they're doing.
Are you seeing patients at Miriam Hospital from the correctional facility here in Rhode Island?
So in Rhode Island, the Department of Corrections scrambled. It was a month ago that the medical director called a meeting and had over a month ago, and said, okay, what are we going to, let's figure out how to plan to do whatever we can to prevent this. And so, the steps that she took and the institution took were really doing whatever they can. First was, get everybody you can out that you can. The second, and a lot of that is not under the control of the Department of Corrections. It's been very interesting to me to figure out that, for example, in Rhode Island, the governor cannot commute anybody's sentence. The governor cannot pardon anybody without Senate approval. So that the Senate's not in session or not meeting. So that's going nowhere. And it's different classes of people that are arrested, that are sentenced, that are on bail, that are eligible for parole, that are there's all these different classes that different groups have the ability to release or not release. I think on each individual case, if you have a bunch of people that are there on bail, bail tells me that the only reason you're there is because you didn't have enough money to pay your bail, so then you have to sit there. Well, right now, that doesn't make any sense to keep people in because it's very expensive. And I don't mean expensive money-wise. I mean it's expensive in terms of having a ventilator bed available when you need one, an ICU bed. So that's the real expense. So just everybody who's eligible for parole, for bail, is there just for bail, just let them out. Call them back when the epidemic is done and say, okay, well,
you're going to have to find them first, but.
Well, they'll find them. Then that's not a problem.
Listen, I heard the Attorney General of the United States, William Barr, when asked the question about federal prisons, which are a relatively small fraction of all incarcerated people, but a non-trivial, we're talking, a couple 100,000 people. And he said, I ain't letting them out. In so many words, that's what he said. I want to ask you, in the spirit of William Barr, I'm obviously devil's advocating here. What about violence? What about violence? I'm going to let violent people out. You say there's no threat to public safety. Well, I've got murderers. I've got, I've got people who severely assaulted people. I've got sexual predators and whatnot. So what about violence? And B, what about the victims? There are people, tens, hundreds of thousands of them, who thought justice was being done when their assailant was punished. And now you're going to abrogate the punishment without even a reference to their feelings.
Sure. So somebody who's there on bail, pretrial detention for whatever reason, they haven't been convicted.
Okay.
If they had the money, they'd be out. So take the low-hanging fruit. That's a low-hanging fruit, should be a low-hanging fruit. Then you have to look individually at each person, each case, each situation, and just decide, where does that balance fit? Is it this person is violent and likely to hurt other people if you let him out? Well, that person maybe shouldn't be let out. Another critical factor that is just a reality factor is many people have no place to go that's safe. The last thing we need to do is fill up the homeless shelters with people we let out. That's not going to help. They're going to spread the virus there just as well, and they're going to be worse off. But many people have been in there for decades and have lost connections with the community and their family and have no place to go. And sending a bunch of people to nursing homes may not be that helpful either. So it's not, you have to, first make that assessment about the public safety risk, how much risk you're willing to tolerate. Traditionally, the parole boards do this. They measure the risk, and they measure the victim's impact, and they measure whatever else they measure, but they tend to be extremely risk averse. but I've talked to the head of our parole board and say now is the time to actually be less risk averse. And then, talking about victims, I mean, on the one hand, uh, I can understand that a victim would want somebody who's been victimized by somebody would want them still incarcerated. On the other hand, I could understand that somebody might not want that person taking up an ICU bed that causes someone else to actually die because they couldn't get in there. So it's a complex situation. There are also other high-profile people that maybe at increased risk for getting ill and maybe at increased risk for occupying an ICU bed, but that it was simply, you know, too politically foolish to let them out. If you let them out, then everybody say, "Oh my God, they're letting this person out," and they shut down all the, everybody would get upset about that. So
I need to ask you this, Jody.
sure.
Were you or have you ever been, so to speak, a prison abolitionist in your prior life before the pandemic came along? A person who advocated the abolition of prisons?
No, I have met prison abolitionists. I've talked with them, and I respect them. And I've met a lot of people, as I mentioned, who've been incarcerated, and I believe a lot of them don't need to be there. But I also believe there's a lot of people that the best alternative that we can come up with is to have them is separated from the rest of society. I don't believe that punishment is actually is helpful in our society. Um, Other people disagree with that, but I think some people, it's that public safety risk, that individual that will hurt other people if left out, and I think that's a sort of a societal public safety argument, and so I think that I do buy that, but I think we're not anywhere near where we should be. A lot of this is the drugs, and
Yeah.
drug addiction is really a disease. And the Europeans look at us like we're absolutely insane. They
Yeah.
say, "Don't you know that punishment doesn't work for addiction?"
Yeah.
And they they don't have their prisons and jails filled up with people who have
Yeah.
addiction as the primary reason for them being there. And of course, it's horribly destructive to that individual, their family, their community, and society in general. And in being incarcerated, there are a lot of people in the throes of addiction that are out of control and are hurting themselves and others and need a timeout. They need to be somewhere else, out of their environment. That is in the moment, that is the best thing. But staying there for long periods of time doesn't help anybody. And I think we can get much better outcomes with treatment, with understanding and using effective treatment.
I want to shift the ground a little bit. I hear you very much on the prison thing. Sounds to me like you're saying in so many words, look, we're shooting ourselves in the foot here. This is going to be a breeding ground for virus transmission. Not only the welfare of these people is at stake, they're going to have to go somewhere and be dealt with if and when they become sick. That's going to be a burden, and it's going to endanger people. Just from a pragmatic point of view, the best course of action is to let as many of them out as you can before that place becomes a teeming cauldron of sick people with the virus.
Yep. Very
Okay.
well said.
I want to shift ground a little bit.
There are other things that can be done. So getting people out is the first step. Preventing infected people from coming in is the second step, or should be done at the same time. And that is very difficult, because one of the first things we did, and I think, Rhode Island Department of Corrections has done it when I've heard. And so far, we haven't had any people who are incarcerated infected that we know of. And there is testing going on, there is screening going on. We've had, I think now, 3 or 4 correctional officers who've been identified. And of course, the whole facility is on film. So the first officer they found, they went back and traced every city using the cameras and figured out who exactly he had interacted with and put all of those people on quarantine. And now 2 or 3 of those since been diagnosed positive. So that, just being vigilant about that was incredibly helpful.
Did I understand you correctly?
That could have been an outbreak there.
Excuse me for interrupting. No incarcerated, sorry, Jody, no incarcerated person in Rhode Island has been found to be testing positive with the virus?
At the Rhode Island Department of Corrections,
Yeah.
I haven't heard about, so that's, now, there's a lot of correctional facilities across the country that have not found anyone who's infected, that actually have a lot of people that are infected. They just haven't been testing.
Yeah.
Or screening for it. So that'll start to turn up.
Okay, I wanted to, I know you got to go, just shift the ground a little bit to ask you about the disease itself. You're treating patients. What's happening to these people? What are the manifestations of the degradation of their bodies caused by the virus? How do they die? It's morbid, but I think I certainly want to know what's going on with sick people with this disease.
There's predominantly it's a pneumonia, and it's severe lungs, so they can't breathe, they can't catch their breath. That's the main manifestation, and that is what people. I mean, people can die from that. We've had deaths in the home of people that didn't want to come in because they didn't want to come into the health system and get infected, didn't know that they were already infected. And that would be someone who died of shortness of breath. There are other people that don't want to be put on a ventilator, don't want to be put on life-saving machines because they have underlying illness and age and so forth, which is perfectly appropriate in many cases. And those individuals, can die from just an inability to get enough oxygen. We thankfully can keep people comfortable in that setting. I have a close friend of mine, I know her, she's a physician, and her father I've known my whole life, and he had a terrible lung disease that was progressive, that got worse and worse, and he ended up dying. And she was with him at the end, and he was getting morphine, and he was just looked really uncomfortable, having trouble breathing. And she said, "Dad, I just feel so helpless and so bad that you're suffering," because he looked like he was suffering. And he was able to tell her, "I feel fine."
Wow.
He was breathing hard. He looked uncomfortable. He was on the appropriate, pain medicines, and felt fine and felt comfortable. So I think that's, it sounds horrible to not have enough oxygen and die that way, and sometimes it is, but doesn't have to be. So
how does the ventilator device work as a part of an overall treatment plan? Is it a palliative, the last resort, or do people get off these ventilators and recover fully at a relatively high rate?
I think that depends upon a lot of things. So once somebody gets onto a ventilator, you pretty much have to sedate them in order to put it's a tube that goes in the mouth or in the nose down into the lungs, and there's a little balloon on it that inflates and creates a seal. and it basically just pumps air in and out. And you can increase the amount of oxygen. You can make it, if somebody is working hard and hard and harder to breathe, eventually they tire out and they can't keep up with it. And at that point, they can die. So you can, now there's devices you can put on that people take at night who have sleep apnea, put that mask on and it helps them breathe, so that can provide some assistance. But then eventually those can't deliver as much oxygen as a ventilator. So then when someone's on a ventilator, they're typically sedated, and it's at least an initial part, and it's it requires really intensive care, close monitoring, suctioning out secretions, and monitoring all kinds of things to keep them supported. So that's basically an intensive care unit, and there are a lot of complications that can occur. But most people that we're finding that if you can support them through it, they can survive before they get to that needing to have a ventilator. The ones that need a ventilator, I haven't seen. I mean, we've seen quite a number of people survive here in our hospital. I haven't seen. I mean, some of the statistics are pretty bad, 80 to 90% not getting out. We haven't seen that here. I'm not sure how much of that is related to the relatively slower increase that we've noticed here, or whether that's from the from this study medication that we're giving to patients. So,
are you expecting to see Rhode Island be able to maintain its relatively lower rate of infection with the disease and mortality as compared to Massachusetts to the north and New York to the south?
I could answer that if we had testing done. If we had any, we're blinded here. Like, we get up every day, don't know how many cases we're going to see. We didn't. Frankly, I thought we might have been overwhelmed at this point, and thankfully we haven't been yet. But the cases are steadily increasing, and have been steadily increasing for the past month. So I haven't seen a turn down yet. I think the preparations that Dr. Clark and the team at the Department of Corrections have done have really been, extremely helpful in delaying any infection getting into this point. Hopefully, now the other things she's done is divided up. She's shut down all visits, but of course you still have correctional personnel coming in and out. She shut that down, I think, 3 or 4 weeks ago, appropriately. She liberalized the use of phones, so people can, the Department of Corrections allowed people to use phones twice a day to make calls for free, which has been, not the case in the past, and make sure they sanitize the phones in between. They're trying to keep as much social distancing as possible. Another key thing is they got the word to law enforcement: stop arresting people. Stop arresting people. If you can give someone a notice to come to court a month from now, or and I think law enforcement got that message. I think they also realized that they're putting themselves at risk by stopping more and more people, and so I think that helped.
That's a new meaning to social distancing. Police officers social distancing themselves from suspects.
Yeah. There's still, there was just in the paper, a double homicide and somebody arrested, and, bad things are still happening. The police need to do what they need to do. But a lot of the stuff that they don't have to, in situations where they don't have to arrest someone, I think they're tending not to. And I, the staff at the Department of Corrections, when they brought someone in, and again, Rhode Island has both the prison and a jail, the same institution, unified institution. Several patients, they stopped right at the door at the gates and said, no, this guy's had a fever, he's been coughing, get him out of here. And somehow that person just happened to make bail that, right, right after that. So I think
Well, when the arrestee population hears this, a lot of people are going to be coughing when the cop stops them.
Yeah, I don't speak for the Department of Corrections. I'm a consultant there, but I am very proud of the work they've done to try and prevent it. They've also separated out into groups of a couple dozen people that stay in that group. So it's kind of like a honeycomb, the whole 2,500 people, so that you don't have people that have just circulated and seen everybody. So these are just, common sense things that they can do, doing the best they can to either prevent it from getting in and slow its spread when it does get in. Now, once it does get in, then you're going to have to do strict monitoring to try and identify those people that are sick that need to get out and get them out. And then separate those that are sick from others.
Okay, Jody, I think I should let you go. You got things to do. I really appreciate you giving us your time. Dr. Josiah Ridge, Warren T. Alpert School of Medicine, Brown University. So thanks a lot.
Glenn, thanks. This is fun. Let's do it again.